Everyone, I will be presenting to you our method for locating vasculature from endoscopic video. Since we just had lunch, I am compelled to tell you that this presentation will contain some graphic surgical video. In essence, by analyzing subpixel motion or flow in endoscopic video sequence, our proposed method can detect pulsating blood vessels even when they're hidden under layers of fat. But before delving into how we accomplish this, I would first like to motivate this application in the context of kidney cancer surgery. Kidney cancer is common. It is ranked among the top 10 most common cancers in both men and women, with each American having a 1 in 63 risk of developing it in their lifetime. Full or partial removal of the kidney, also known as nephrectomy, remains the most common and successful solution for this particular type of cancer, specifically renal cell carcinoma. Robot-assisted, I should start by saying that we do have a redundant pair of kidneys, but the radical removal of one of them could have dire consequences to our health. But if the cancer is detected at an early stage, a partial nephrectomy may be performed. Now, whether done laparoscopically or with the aid of surgical robots, these techniques improve outcome by only removing the tumor and partially preserving the kidney's functionality. Robot-assisted partial nephrectomy can be decomposed into 5 stages, starting with demobilization of the intestines to gain access to the peritoneum, then hilar dissection, which entails the removal of the connective tissue around the vasculature located at the hilum, identification and demarcation of the tumor margins, clamping and resection of the tumor, and finally reconstruction of the kidney itself, which is referred to as renography. Now, all these 5 stages pose great challenges and ample research opportunity for the MICCAI community, but for us, the second stage, hilar dissection, stood out as a very challenging, daunting, and time-consuming stage of the operation. If all of the blood vessels flowing into and out of the kidney are not located and prepared to be later clamped before the resection, intraoperative bleeding will occur. Bleeding is especially bad during partial nephrectomy because it occludes the surgeon's view of the collecting systems and other structures inside the kidney. And this is especially challenging because the arteries are buried under many layers of connective tissue, including the peritoneum, the germoidal fascia, and the perinephric fat. Further complications result from variation in patient's vascular anatomy. This visualization captures the variation in renal arterial structures among 266 different kidneys, and the presence of accessory renal arteries. This implies that the surgeon needs to identify and locate all of these accessory arteries such that the bleeding doesn't happen during the intervention. Currently, surgeons rely on segmented preoperative medical images for guidance, and many methods have been proposed to sync these preoperative models with surgical video, but most of these methods haven't been extensively validated in a clinical setting, most likely because they rely on delicate selection of complicated parameters, are very computationally complex, they can't perform in real time, or they use invasive dilutions and things like that. Recent methods favor the use of fluorescence imaging, such as the firefly fluorescence imaging shown here. These methods are cost restrictive, are dosage dependent, require invasive injections of fluorescence dyes, and fail to identify vessels who are deeply occluded by fat. In these videos, you can see that only the visible part of the vessels are fluorescent. To address the need for methods that don't rely on harmful imaging or expensive equipment, the recent popular Eulerian magnification method of Wu et al. From CSAIL has been extended to robotic surgery by McLeod et al. to enhance the appearance of vasculature by emphasizing motion. However, the emphasis of motion doesn't really attract the surgeon's attention to location where the vessels are. So we hypothesize that if we can identify and enhance motion of vasculature, we should be able to label it accordingly. And labeling became a very important goal for us because the artificial motions applied to surgical videos was perceived as a nuisance by our collaborating surgeons. So, to expose the method in a very intuitive way, I will use this framework. Take, for example, an input video with localized motion. If we zoom into this video, the subtle motion is visible on the top circle. We know from wavelet theory that local motion is related to the change in local phase. So to measure local phase, we use the following decomposition proposed by Simon, Chile, and Freeman. The recursive block diagram is shown to the right. And after applying these filters to the to every frame of the original video, we can extract local phase and local magnitude from the complex filter outputs. And then, since I mentioned that motion is the change in local phase, we can measure this change by applying a simple temporal bandpass filter. This could be an ideal filter, for example. After applying this filter, we notice that there's change in phase in location in regions where there's no strong magnitude information. So to attenuate these regions, we just take the per pixel product of the magnitude with the bandpass phase information. And another important consideration to be made at this point is in regards to the wrapped nature of local phase measurements, and this results in impulsive noise after the phase has been bandpassed. So to deal with this type of noise, we just apply a spatial temporal median filter, and the resulting outputs are then collapsed back and added together using a magnitude weighted averaging scheme. The resulting labels, overlays can either be shown as they are, or they can be added back to the original video in an augmented reality manner, so the surgeon knows exactly what is pulsating. To validate our method, we opted to choose 8 very challenging cases from robot-assisted partial nephrectomy. From these 8 cases, we selected 4-second clips in which there was no large camera motion, of course. And then, furthermore, we manually or semi-automatically segmented the preoperative images corresponding to each patient. And we chose to segment the kidney, the tumor, the arteries, the vasculature, and other organs. We use these other organs, including the spleen, the liver, and the ribs, to manually align these segmentations onto the first frame of the endoscopic video. And this essentially generated a ground truth against which we could evaluate our localization of the vessels, as you can see here. So the very first interesting observation that we made is that we had enough temporal resolution to differentiate between arteries and veins. In this particular example, the arterial pulsation occurred 2 frames before the venous pulsation. And the periodic nature of these pulsations are visible in the temporal cross-section of the video shown in the middle. So to emphasize this better, we changed the color map of the arterial pulsations to red and the venous pulsations to blue. And going through our qualitative results, you can see that we clearly identified the renal vein and the inferior vena cava. Even though small motion artifacts were present on the tools, we attribute these motion artifacts to the fact that the tools vibrate from the pulsatile motion through the abdominal wall. Nevertheless, we correctly identified the small renal artery located at the bottom of the image. In this example, we identified the inferior vena cava through the surgical gauze that was on the scene, and the small accessory renal artery that was at the highlight. In our last example, you can see that we identified the fully occluded renal vein and the partially occluded renal artery. Quantitative validation of our method was also performed to evaluate how effective we were at labeling vessels in general. What we did was we thresholded the vascular motion labels for every frame in the sequence and combined it throughout the video and looked at the sensitivity and specificity for all the 8 cases. And we measured a mean area under the curve of 0.76 for this very challenging data set. To summarize our contributions, we developed a method for segmenting vasculature based on their motion. We validated our method on 8 real and challenging cases of robot-assisted partial nephrectomy. We demonstrated that we can visually differentiate between arterial and venous structures at the renal highway. And finally, we're hoping to extend this method by incorporating shape hires to reduce the number of false positives that we're getting. Also to extend our method such that it can perform in real time. And finally, to assess its applicability to other interventions. And I would like to also conclude by thanking all of my colleagues and to answer any questions which you may have regarding this method. And I will leave you with a video just to summarize what I'm doing. Thank you.
Okay, thanks a lot. So the paper is open for questions, and again, there are microphones in the back and front of the